So I'm so grateful that you come out on this rainy, dreary night. And I hope we can have kind of a conversation tonight about RODBT. And my goal is to give you an idea about what RO is. It's a very complicated therapy, so I'm going to try to give you just an overview of it and hopefully answer any questions that you might have and meet your goals for being here tonight. Does that sound okay? All right, let's get started. That's just a disclaimer. I make no profit from this. I'm not selling anything. I have no conflict of interest. So I've been a therapist for many, many years, and it's a passion for me. I care about the people I see, and it's really important to me when I go in that room that I can do the very best job I can. And I'm sure it's the same for you. You wouldn't be here if it wasn't. And there's so much pain involved in the people that we see. And in my practice for a long time, there was a group of people that I couldn't help. I didn't know what to do to help them. And those people turned out to be mostly people with the diagnosis of borderline personality disorder. So then I learned DBT. And I had something to do. I had something that could work. I had a way to help them. But there was still a group of people that I wasn't reaching. And I don't know if you're seeing this type of client or not, but people would come into the practice and they would have very intense anxiety. They would have very limited ability to form relationships, perfectionistic. They weren't getting into trouble, but they weren't connecting, and they were miserable, chronically depressed, not able to really make a life that they could enjoy and live. And DBT wasn't reaching them. And so that's when I discovered RODBT. I think that I've been blessed in a way to be alive now at this time, because we as therapists, I think, are at a crossroads. Our profession is changing. And it's changing. Well, let me ask you, can you as therapist, does everyone who comes to see you get better? Do you have people that you struggle to help? Yes? Okay. That's why I think we're at a crossroads. Because our profession is starting to make some developments that are making a huge difference in the way that we practice and the people that we can help. Right now, we have a significant number of people that aren't benefiting from the treatments that we're offering. A significant number of people that have chronic disorders and aren't getting well. And our existing treatments just aren't working. We're not reaching a large number of people that need our services. Not from lack of trying, but our treatments aren't matching. They're not working with the people that we're seeing. In years back, we tended to blame the client. Treatment resistant, client. The client isn't doing what we ask, non-cooperative. Sometimes I think maybe that was a way we had of protecting ourselves, because it's so hard to watch a client not get well. Especially in certain diagnoses, we're not doing a very good job. Chronic depression, anorexia, very difficult to treat. In depression, right now we're helping about 1/3. 1/3 are getting somewhat better, and 1/3 are not improving at all. So what about all these evidence-based treatments? And I'm talking about one tonight. What about our evidence-based treatments? Well, part of the problem is that a lot of times the evidence-based treatments are being tested with a very select group of people. For example, if they have a new treatment for a panic disorder, it's tested just on people that have panic disorder and nothing else. And that diagnosis is very carefully done. with a lot of assessment to be sure that there's nothing else going on. But that's not the client that you and I see. What we see in the real world are people with very complex disorders, mostly. We see people that are coming in with a multitude of diagnoses. I see people sometimes that have 8, 9 diagnoses. What's going on with that? And how does that help you know what to do to help the person when they come in with 6, 7, 8 diagnoses? You see, one of the things that's going on that we've realized, and that's going to help us as clinicians, is to recognize that a large number of people that we haven't been able to help, it's because they have an underlying personality disorder. Now, when I first started working as a clinician, we didn't address personality disorders at all because we didn't know what to do. But we're starting to learn what to do, and we're learning how important it is to pay attention to underlying personality disorders. So, remember I was talking about the multiple diagnoses? 45% of the people that have depression also have a personality disorder. 51% people with anxiety also have a personality disorder. 65% of the people that have anxiety also have an eating disorder. And 52% of the people that have an eating disorder have a personality disorder. So if we try to treat just the anxiety disorder, or we try to treat just the depression, it's going to be a real challenge. Because what's really may be going on is that underlying personality disorder. How frequent are personality disorders? Is it really enough to impact our treatment with the people that we're seeing? It's much more prevalent than we originally thought. The research is showing something like this, that the distribution of personality disorders, this is for chronically depressed mid to older adult sample, and in that sample, look at the personality disorders that they found. And the number one personality disorder, don't look. What do you think the number one personality disorder would be? Most people guess borderline because borderline personality disorder has gotten a lot of publicity. But it's not. The most prevalent, 39%, is obsessive compulsive personality disorder. Paranoid's 11%, schizotypal was 3%, narcissistic's 5%, borderline was 10%. But the point for me here that I want to share with you is look at the large number of people in a depressed population that had a personality disorder. Total was 73%. So if you think about the people that are coming in to see you, a large number of the people, especially people who aren't responding to initial treatment, probably have a personality disorder. And the other thing that we're beginning to realize is that our diagnostic system is kind of broken. That our diagnoses aren't helping us determine the treatment that is best suited for the client. And this is being recognized by NIMH. It's being recognized by the people who hand out all these large research grants, which is where our therapies come from. So much so that they will no longer fund any research that's based on a diagnosis. What we're looking for are treatments that are called transdiagnostic. Have you guys heard that term? Transdiagnostic. What it means is we need an underlying core disorder that we can treat the disorder and not the diagnosis. And I'll explain more about that later. But the National Institute of Mental Health, they will not fund any more research. They want transdiagnostic methods, methods that it's a new way of classifying psychopathology to try to look at the underlying core and what can we treat that's underlying these diagnoses that makes sense so that one treatment can be used for many different people and be effective. So that's where RODBT comes in. RODBT is a transdiagnostic treatment, and it is a treatment for people who have what we call maladaptive OverControl. RODBT is informed by dialectical philosophy, behavior therapy, mindfulness, and Malamate Sufism, which is a form of meditation, like Zen. It has been researched for over 20 years, and it has a strong research basis. It's been treated with they've treated over 350 patients in research trials over the world. Now, in comparison, when DBT was first released, there were 22 patients that had been seen in the research trials. So he waited a long time before he actually released the treatment. It is evidence-based, and here are the main research trials that have been done. 3 with anorexia nervosa, and it's really gotten amazing results with anorexia, which almost nobody is getting. And the last one is a research study that was done without the treatment developer involved. And it was only, like RODBT has an individual component and it has a skills class, just like DBT. And the last one was done only with a skills class. And they still got significant changes and results. So if you are interested in the research, I could talk about it more, but I want to sort of move on tonight, but I'm happy to give you those if you are interested. So what is the difference between RODBT and other therapies? I mean, what's going on? Let's get more specific about it being transdiagnostic. So in RODBT, it's not anorexia that's the problem. It's not obsessive compulsive personality disorder that's the problem. The problem is the underlying, the underlying maladaptive overcontrol personality. And I'm going to explain more about this, but the maladaptive overcontrol personality leads to what we call social signaling deficits. And those social signaling deficits leads to an inability to form close connections with other people. So what we're coming down to is the idea of loneliness. And in the research recently, well, not so recently, but they are beginning to say, they're beginning to look at, they're beginning to find that loneliness in itself is something we need to treat. That loneliness has been seen to come first, before the depression and before the anxiety. The World Health Organization, the director, has said that we have an epidemic of loneliness in the world. Researchers are saying we need a treatment that not says loneliness is part of depression, but it's something that we need to treat directly. It is in itself a cause for many of the disorders that people are suffering from. So we just say, hey, people, join a group. Go to church. Invite your neighbors over. The problem is it doesn't work. Like, in fact, I think it was Australia that sort of tried that to try to set people up with groups of people. Now, there's some people that can do that. But there's a whole group of people that I've been talking about that can't. And it comes from that over-control personality that they have, and they're not able to connect with, they don't have the skills to connect with other people. So just putting them in a group of people doesn't work. So what we're saying is that anorexia is not the problem because before the person developed the anorexia, they had perfectionism. Before they developed anorexia, they had rigid rule-governed behavior. Lots of rules about the way that they could interact with other people. They had inhibition of emotion, difficulty expressing emotions to other people. And they had sort of a need to be in control. That came before the anorexia. That is what we're saying is the underlying cause. And it can lead to different disorders. But those symptoms are what lead to the disorders that we are calling diagnoses. So we're going to look what do I mean by social signaling? Why are we talking about social signaling? And why is that so important in RODBT? So remember I said loneliness comes from a deficit in social signaling, comes from that overcontrolled personality, right? So the way it came about was looking at evolutionary science, how we developed, how we came to be the tribe we are today. So what we needed to survive as human beings, can you think about that for a minute? 200,000 years ago, how did we survive? There's thick-skinned dinosaurs, pterodactyls, claws, animals with these big claws. We're thin-skinned, we can't fly, we can't run that fast. How did we survive? Because what we're trying to look at is what worked for us. And one of the things that we know is that we developed, in fact, there's a cooperative gene that actually developed that we as humans have. And that is one of the things that helped us bind together as a tribe. And being a member of the tribe was part of survival. And we still have that. We still have, if you feel left out or rejected, think about how painful that is. We've all had that experience. Public speaking. The main reason most people fear public speaking is because you'll look out and there'll be this one person, perhaps, that has a flat face. They're not giving you any signals that you're doing a good job. We read that, and we're going to talk more about that later, but we read that as rejection, and we hate it. Because being out of the tribe is scary because that's the way we survive. So this group of people that can't connect feel out of tribe all the time. And our job in therapy is to help them get back in the tribe and help them connect and help them overcome. But this is a way of understanding why it's so important, because our survival depended on being part of the tribe, sharing food, being able to fight off predators, being able to help each other, fire, share things. So social bonds and self-control are really important. And that comes about through evolution, and it's really important. And it's important in relationships. To be able to have self-control is important. You inhibit your urge. If I get mad at you, I don't just punch you in the face. I got self-control. You'll be glad to hear that. And it helps us to pursue long-term goals for our tribe. So self-control started to become very valuable. It meant that people wouldn't eat up all the food of the tribe. They could save it for a rainy day and for winter. Self-control means that you could work together, have common goals. So through evolution, self-control became very important. Lack of self-control is very eye-catching. Lack of self-control is when you are impulsive, you're loud. You are just saying, give me that. You make me mad. I don't want to be with you anymore. I hate you. Wait a minute. Why won't you play with me? That kind of stuff. Lack of self-control is borderline personality disorder. So one of the things I'm trying to make a comparison with is self-control became very valued by the tribe and very necessary. One of the reasons that mental health is focused on borderline personality disorder and the lack of self-control is because it's so loud, it's in our face, and it goes against the tribe. And so we see that as pathological, and we worked to treat it. And I think that's one of the reasons it's gotten so much attention. Are you with me? Is this making sense? Okay. But overcontrolled was kind of overlooked because they're not roaming the streets in gangs. They're not yelling. They're not telling you they hate you one minute and they love you the next. They're not acting on impulse. They don't feel like going to work, so they don't go to work. That's not happening with overcontrolled people. They are hyper detail focused, they're perfectionistic, they have duty, they have obligation, they see mistakes everywhere, including themselves, they're hypercritical, and they tend to work really hard to prevent problems, really hard, and fix things. They want to fix things. So those are people that really don't look like there's anything wrong with them. They're expert at looking like there's nothing wrong with them. They can come into your office and tell you they're depressed, and it's really hard to figure out what's going on because they work hard, they have a job, they're often high achievers. So what's going on? And they don't show the distress that they're feeling inside. So OverControl is very pro-social. It's something that we kind of desire. They desire to be correct. They value rules. They have the ability to delay gratification. And they have a strong sense of self-sacrifice and duty. But can you have much of a good thing? This says the therapist is actually laying on the couch and the client is sitting in the chair. And it says, everyone accuses me of being a control freak. So the question is, we don't want to turn anybody into borderline personality disorder, but can you have too much of a good thing? Can you have too much self-control? And this is the way we've kind of looked at it in mental health in terms of self-control. We've kind of looked at it, if psychological well-being is on this axis, up and down axis, and self-control tendencies is this way, we sort of looked at it as the more control, the better. We've been teaching people how to control. Let me teach you how to control your anger. Let me teach you how to control being sad. Let me teach you how to control. We've sort of looked at it that way, the better. And if you look at it from the evolutionary science point of view, you can see how maybe that came about, how we valued self-control so much that we were a little bit blind to this whole group of people that have too much self-control. So this is the new model. It's a bell curve. Kind of makes sense, doesn't it? So over here is that little group. Oh, wait. Do I have a little light? Yes. Right here. I get excited by little things. So right here, this is the under control people. Here's psychological well-being. Here's self-control. So the more self-control goes out this way. This is the most self-control. And this is the most psychological well-being. So it's actually that there's a level of optimal control that people can have that really makes their lives easier to live, that they are able to have contentment, they're able to live their life in a way that is rewarding. Under control is right here. There's where the person with BPD is. But over here is another group of people. And this is the maladaptive over-control group of people. They have too much control. They are so rigid that they can't enjoy their life. Their rules are too strict. They can't express their emotions. They tend to be, their facial expressions can be fake, or they're seen that way, and they don't really know how to have fun. They don't know how to relax. They may have 3 degrees from Ivy League universities, not necessarily, but they may, but they don't know how to celebrate their child's birthday. They don't know how to play. So this is the model from which RODBT is coming, that we have people over here that we need to pay attention to. So how does that sort of lay out with diagnoses? So let's take a look at that. So this over here is the under control. These are the diagnoses that tend to be with more of an under control temperament. So the two we're looking at, the researchers all over the world actually have started to agree that the personality types that underline the diagnosis are 2. One of them is under controlled and the other one is over controlled. People have different names for it, but they're coming down to basically two, under-controlled and over-controlled. And so we want a trans-diagnostic treatment that can treat all these diagnoses for under-controlled and all of these for over-controlled effectively. And we're looking at that underlying cause. So essentially, obsessive-compulsive personality disorder, which was 39% of those people that were depressed, I think it was 39, is over here on over-controlled. Treatment resistance anxiety, and mostly all the internalizing disorders, if you're familiar with that term. Internalizing disorders tend to be over here on over-controlled. There are, let's see, a couple of comments I want to make. Binge purge eating disorders. What we actually know is that binge purge eating disorders can be in either category. There can be a binge purge person who it just happens, there's like no set to it, there's no pattern to it. But there are some people that schedule their binges and schedule their purges. And it's very planned out. That person has over-controlled, maladaptive over-control. So sometimes we have to look underneath. There's something else that I want to bring up. And that is that I think for a while, I don't know about if it's true for you or not, but for a while, I think that there was sort of a general idea that if somebody did self-harm, that probably indicated that they had borderline personality disorder. But what we know is that's not true at all. People could do self-harm and also be over here with over-controlled. It's how they do it. If somebody does self-harm impulsively and it doesn't seem to matter who sees it, it's more likely to be under control, not necessarily BPD, but under control. If it's planned very carefully, it's done in private, and it's typically done to punish themselves, because over-control people have a very strong sense of justice and fairness, and that they need to do the right thing, and so they will punish themselves sometimes with self-harm. And it'll be very private. So I just wanted to make that point. People ask sometimes about attention deficit. Where does that fall? We don't really know yet. Research is still working on it. And so I can't really answer that one. Any questions so far? Yes. Yes. That's where we're going. Like you as clinicians, the idea is that if you have someone with an under-controlled personality temperament, that treatment is completely different than someone who has an over-controlled underlying personality temperament that is over-controlled. Now think about it for a minute. If someone is too rigid, too rule-oriented, inhibits their emotions, do we really want to teach them how to have more control? You know? We want to teach these folks over here how to have more control. These folks over here, we need them to lighten up. We need them to chill out a little. Have some fun. So it's a completely different treatment. Yes. 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 In certain situations, if the symptom appears to be under control. Okay, so let me just make it harder, all right? Why not? Let's say that you have a client. Okay, I recently had a client who had anorexia, severe anorexia. And she was screaming at her mom, calling her names, treating her terribly. Now, that sounds like a contradiction. It sounds like I've got an over-control disorder, the anorexia, and an under-control behavior, like screaming and yelling at people. But here's the thing. People who have over-controlled are different in public than they are in private. And so any situation that they consider private, they may behave in ways that they're angry or they are more, they're not following the rules so much. So you have to determine. With me, she was the most soft, she wouldn't even disagree with me in the beginning. And she was the most soft-spoken person. So you have to determine, is it a private behavior where they think no one is seeing them, which, by the way, includes a car. You know how people pick their nose in their car? Okay, so that seems to be it's considered private. I don't know. Your office, for some people, may also be private. It's sanctioned. I can sort of let my emotions go with you. So the assessment has to be done pretty carefully to see how do they behave at work, how do they behave in what they consider more public situations where they're not sanctioned to just let go. A person with under control can't do that. They're always loud. They're always impulsive. They cannot say, in this situation I'll be this way, and in this situation I'll be a different way. Good question. Okay. So over-control, this is what we've been talking about, just summarizing. Over-control is a problem of emotional loneliness secondary to low openness, not expressing themselves, not letting people know who they are, and social signaling deficits. So 4 core deficits of someone who has over-control. Lack of receptivity and openness. Now what that means is to have psychological health and to learn, we have to be open to feedback. We have to listen to other people. Say, hey, Karen, you talk too much sometimes. So people don't like that. So why don't you kind of tone it down a little bit so you can, I think you'd get along better with your friends. People who are over-controlled do not accept feedback. You're out of their life. They'll walk away if they get angry enough. They don't listen. You don't know what you're talking about. They're very closed to feedback. They avoid new situations because they like predictability. So they'll stay in the same kind of situation over and over. They'll eat at the same place. They'll go to work the same way. They go home and watch the same shows. They stick to a routine. They also have lack of flexible responding. If they usually take a walk at 7 o'clock in the evening and somebody drops by and says, hey, let's play some cards, I have to go for my walk. Mom calls. I said, I can't talk to you right now. It's time for me to prepare my meals for next week. There's no flexibility in the responding. And so we need flexibility. Like if we go to London, we got to have the flexibility to drive on the other side of the road. And that's part of psychological health. And someone with over-control can't do that. Lack of emotional expression and awareness. And this is the one that gets to social signaling. So people who have over-controlled do not show on their face and in their interactions what they're experiencing on the inside. And sometimes they're not even aware of what they're experiencing on the inside. So I come into you and I say, yes, I'm feeling very anxious. Are you going to help me? Are you going to fix it? This isn't helpful. Or it can be like this. You're going to help me. I know you will. Yeah. And I'm exaggerating a little bit, but there's a mask that someone with over-control wears because they can't allow themselves to be vulnerable. And without vulnerability, you can't connect to other people. And so it's hidden what they're expressing. And there's a reason for it. I mean, they have grown up in families where it wasn't allowed, or they grew up in families where the expression of emotion was so scary and overwhelming that they shut themselves down. They grew up in families where it was important to achieve and be perfect. And so you can't let someone see that you're not feeling confident or perfect or that you have any faults. So they wear a mask. But unfortunately, that becomes like an armor because it blocks our ability to connect with each other because emotions communicate to other people. The way you know if you can trust me or not often is by my showing you who I am, showing you how I feel and what I think. And if I inhibit my opinions, I inhibit my emotional expression, you don't know who I am. You don't trust me because you don't know who I am. And you don't connect. But they are totally unaware that that's going on. Sometimes they know they've been told they have a flat face. Sometimes, and flat face is just one part. But a lot of times they have no idea how they are looking to other people. And then they have very aloof and distant relationships because they can't connect. And what we know is to have psychological health, we have to have at least one connection in our lives that is intimate and close. And so part of our work with people a big part of our work with people who are overcontrolled is working toward their being able to connect with other people. All of that, of course, leads to that emotional loneliness that we've been talking about. Now, here's the thing. What would you guess I am? And I do have a style. And you guys do too. Because I've been talking about over-controlled and under-controlled in a pathological way. But we all tend to be either under-controlled or over-controlled. And it's not necessarily pathological. So you heard me use the word maladaptive over-control, maladaptive over-control. So people can be over-controlled and not be maladaptive. People can be under-controlled and not be maladaptive. So there's a difference that everybody has a personality. We want to have a personality, and that's your personality type. So how many of you would say that I am under-controlled? How many of you would say that I am over-controlled? How did you know? How did you know? Structure. My what? Organization. Thorough. Look, I'm surprised because I think I have so much expression in my face that I think people think I'm under control, but I'm not. You're right. I am over-controlled. I am over-controlled. It's that, by the way, you just did something really important because the research shows that other people pick up on it sometimes within 30 seconds, that you get how somebody else is. Now, you don't necessarily get it about yourself. So I'm going to out myself here. It took me a year, to figure out that I was over control. I thought I was under control for the longest time. And I would go into the RO trainings. I'd say, because so many people, actually a lot of therapists are over control. But I thought I was different. So I'd go into the RO trainings and say, hi, here I am. I'm Karen. I'm your under control person. And they would all just, And they kept giving me feedback. And so finally I listened. So you're not usually so good at knowing yourself. So that you might ask your friends. And there is a word checklist that you can use to assess your own style if you want to know. And it's available in the RO textbook. I have a copy I can send here. But you just have to choose one or the other. Are you impulsive or are you deliberate? And then there's a whole list of them. And it doesn't matter. This is not pathology. It doesn't matter if you've got all Bs. That still does not mean it's maladaptive. It just means that's your personality style. And it's kind of cool to know what it is. It's also cool because over-control clients will ask you. Over-control clients will read the book on RODBT and come in and sit down and say, I read the book. So, what type of personality do you have? And so it's kind of cool because what we want to model, remember, people who are over control tend to be uptight. So what we want to model is a little bit more laid back. It's not such a big deal. Yeah, I'm over-controlled. That there's not something wrong with it. Because there's not. Remember all the positive things about being over-controlled? That if I have surgery, I want a surgeon that's over-controlled. I want somebody that's very perfectionistic. We want to take care of the maladaptive part, not change who they are. So, biotemperament, we already talked about that. Oh, well, let me just say this. So, one of the ways to know, sometimes when it's hard to figure it out, about someone who is over-controlled or under-controlled, is to go back to about age 4 or 5 and say, what type of child were you? Were you the kind of child that was getting in trouble, snatching cookies from other kids, or gobbling them up as soon as you got the cookie? Are you the kid that was running around? Or were you the kid that was shy and timid? At age 4 and 5, temperament's evident. Sometimes that's before the environment sort of comes in and changes things a lot, especially if people might have had trauma or things happen that it's sort of hard to figure out what their underlying temperament is. And so the looking at age 5, age 4 is sort of one of the ways to do that. What were you like then? And by the way, there's research that the children who were over-controlled as kids often were bullied and picked on. And so what we think, we don't know this yet, but some of the shootings and things like that are happening with kids that saying, wow, you'd never know that he was going to do that. We think that may be the over-control people, because over-control people in prisons tend to be like that. It's like nothing, nothing, nothing. Then they did something that was very planned and big, and then that was it. They're in prison. So that over-control people, sometimes when they stuff and stuff and stuff and stuff, then they kind of explode. So how did I get into, and they were bullied and they feel left out. They feel like they don't fit in the tribe. So it comes out as this bitterness and resentment toward schools, toward organizations, etc. So biotemperament matters. Thank you. This is an old study, and it was done to look at something totally different. But when we go back and look at the research, we're sort of beginning to see how we can see the differences in temperament of young children. And so this is the first video that I want to show you. And just look and see if you can tell who's over-controlled and who's under-controlled. Oh, can you stop it just a second? I didn't give you enough of an explanation. The researcher comes in and he says, I've got something for you. Here, this is a marshmallow. You can eat this marshmallow now, but if you wait, I've got to leave the room for a few minutes. If you wait till I come back, I'll give you another one. You can have 2. So this is what the kids do when the researcher leaves the room. I'm sorry. Under controlled or over? Oh, look at her trying to cope. It's going to go all the way. Under controlled or over? Yeah. So that's the thing, like at age 4 and 5, we can see this. Now, this is not maladaptive. This is just temperament that we're looking at. But what does the person learn? So the person that comes into this world with a temperament that is under-controlled, they learn, if I escalate things, if I get bigger, then good things happen. That's when I throw temper tantrums until I get my way, or I beg and beg and beg and beg until they give in to me, or I threaten to do things. I'm going to cut my wrist if you don't do this for me. They learn that if you get bigger and bigger and bigger, that good things happen. But that's not what the over-control person learns. The overcontrol person in this family is different, and they learn that if they inhibit and don't express what's going on the inside, that then good things happen to them. So they get more and more inhibited. So the environment works with the genetics, the biology. The problem is for the overcontrol person that they learn this, they've got this already genetic tendency to inhibit, be more reserved, be more restrained. And they learn from their family that that's good. Stiff upper lip. Never let them see you sweat. But when the context calls for some expression, like a friend drops by and you don't get it, you don't get that emotional expression of say, hey, how you doing? You get that flat face. It matters. That not being able to express your emotions matters. And what we know, what emotion would you say this person is expressing? What emotion? Irritation. Anger. Most people that see a flat face, see if I can do it, see anger. And that's because of evolution. Because we were designed to be sensitive to something that could be threatening. And a flat face is, we don't know what it is, so we tend to see it as anger to protect ourselves. So that's why cooperative smiles, when we meet people, is a way to say, I'm not going to hurt you. Yeah, so when someone doesn't do that, then it triggers us to get threatening. So that can happen, by the way, in the office with you. When somebody comes in and they don't signal, hi, how are you? And they've got this, it can cause sort of a threat reaction in you. And that keeps you from being the best therapist you could be. So we have ways of teaching you how to deal with that, because that's hardwired. You can't help it. It's hardwired to react to a flat face as, ugh, are they angry at me? So the expression of emotion matters. Oh, well, here we go. This is sort of trying to look at the biology. Now, were attachment studies, but I want you to look at it from the view of what we're talking about social signaling and how it affects other people.
Babies this young are extremely responsive to the emotions and the reactivity and the social interaction that they get from the world around them. This is something that we started studying 30, 40 years ago, when people didn't think that infants could engage in social interaction. In the still face experiment, what the mother did was she sits down and she's playing with her baby, who's about a year of age.
I'm like a girl. Oh.
And she gives a greeting to the baby gives a greeting back to her.
Yeah.
This baby starts pointing at different places in the world, and the mother's trying to engage her and play with her. They're working to coordinate their emotions and their intentions, what they want to do in the world. And that's really what the baby is used to. And then we ask the mother to not respond to the baby. The baby very quickly picks up on this, and then she uses all of her abilities to try and get the mother back. She smiles at the mother. She points because she's used to the mother looking where she points. The baby puts both hands up in front of her and says, "What's happening here?" She makes that screechy sound at the mother, like, come on, why aren't we doing this? Even in this 2 minutes, when they don't get the normal reaction, they react with negative emotions, they turn away, they feel the stress of it, they actually may lose control of their posture because of the stress that they're experiencing.
Okay. I'm here. And what are you doing? Oh, yes. Oh, what a big girl.
It's a little like
Okay,
the good, the bad, and the ugly. The good is...
So all that happened was the mother quit, just became blank. She was still there. She just became blank. And so it's just an example of how powerful social signaling can be. So how we social signal strongly affects our relationships. And my message to you is that that is one of the core ways that RODBT looks at helping people who have maladaptive overcontrol. Like people with autism and Asperger's syndrome would fit in this category too. And so one of the ways we look is by looking at social signaling, how they're signaling to other people, how they're signaling what's inside them. Okay. And so we're going to do one more thing because I'm running out of time. But I want to try to give you an experience of social signaling yourself. Okay? So I'm going to set it up by the first thing I'm going to do is play this video. This is just a comedy show. And it's about signaling with eyebrows. And it turns out that evolutionarily, our eyebrows are very important in the way we social signal to other people. So after this, we're going to do a little experiment. Okay.
Things I'll be talking about tonight will involve having my eyebrows up. It's not to say that I don't put them down from time to time, but most of the time. Yeah, probably shouldn't have mentioned it at the start, because what happens is people just end up looking at your eyebrows and don't really listen to what you're saying. Just watching these two little bits of fur move up and down. But it is important to know where your eyebrows are when you're talking. Always have your eyebrows up when you're asking someone where the toilets are. Do you know where the toilets are? Toilets? Don't be going, do you know where the toilets are? Toilets. Or, is that your daughter? Is it? Is that your daughter? Do you know where the toilets are?
So that's just an example for you that RODBT is a therapy that people have to feel, because if I just told you, hey, your eyebrows are important, you probably say, oh, what did you learn tonight? Like, this lady. And now you have a feeling for it, about what we're talking about this social signaling and how it impacts other people and how it affects you. So there's a training coming to Houston in April for Radically Open DBT, if you're interested. And I think my time is up. Is that right? I have till 8. Oh, wow. Okay. All right. So now we can. Okay. So we're going to learn something else, and then I'll take questions. So this is what we're going to learn. The person who is overcontrolled tends to live in what we call threat. So neurologically, there are like 5 different sets, neurological sets, that you can be in. One of them is safety, one of them is novel, one of them is threat, one is reward, and one is overwhelmed. So we go up and down through all the neurologically ways of responding. Our nervous system has substrates, and our nervous system actually switches. Like if we're in safety, then it switches to a different substrate if we go into threat, for example. So threat is when we are hyper alert and we're tense and we think there's danger. And we are neurologically in that substrate for threat. Safety is when we're all chilled out, our voice is melodic, we're relaxed. When we're in safety is the only time that we can form relationships. Because when we're in threat, we're just alert to danger. And our voice is not melodic. We're not smiling. We're not sending out friendly signals. We're hyper-focused on danger. And so what we know is the people who tend to have maladaptive overcontrolled tend to live in threat. They live in that tension. And they live with that hyper-alertness to danger. And social situations feel dangerous to them. And a lot of times, especially if they've been bullied as children, which a lot of them were, then they feel this threat being around people. Yes. Safety. So safety is relaxed, chilling out, drinking hot tea, and our face can move. We got all these muscles in our face. We can make all these expressions. We only use about 100 of the muscles, but that's it. And we can swivel our neck. We can look around. So safety is where we're collegial. We want to make friends. We want to have fun. The next one is novel. And novel's like the animal that's like, what is it? What's going on? I don't know what this is. So if we heard a loud noise outside, we might all stop and listen. What is that? In novel, you're trying to figure out, is this like something I'm going to enjoy? Is this a rewarding experience? Or is it a threat? Like in novel, let's say we're having lunch together in a restaurant and we see a big group of people down at the end of the road and they're like shouting. Novel is, what is it? What's going on? Because we're not sure yet. You, generally speaking, you can only be in one substrate at a time. So if you're in safety, you can't also be in novel. So safety gets shut off when you move into novel. Novel, novel. Okay, so now, if you have a temperament that tends to be over-controlled, you see this group of people at the end of the street, you stop, you're in novel. What do you think you're going to think? Danger. It's a riot. Let's get out of here. Let's move. Let's get the other way. They perceive danger. They lean toward danger. Okay, what if you're not over-controlled? You see that group of people down at the end of the street. Novel. What is that? What are you going to say? Yes, let's go check it. I think it's a parade. It's a party. Let's go. So it's a different way of perceiving the world. And they tend to live pretty much in threat. The 5. Safety, novel, threat, reward. This is exciting. It's going to be wonderful. And overwhelmed, which is frozen. And by the way, overwhelmed is where people with anorexia and chronic depression tend to be. They're in overwhelmed. And when you're in overwhelmed, you don't feel anything. You're numb. It's like the frog that plays dead when he's in danger. And it's a way of not feeling because you're so scared. You're just overwhelmed. You're so scared. Hang on. So the person with overwhelmed, it brings up a problem for treatment because when you come out of overwhelmed, you're going into threat. So nobody wants that, so they go back to overwhelmed. It's like I start to come out of anorexia and I start to eat and everything's so scary. I don't want that, so I go back where I can be numb. So another part of RODBT is how we work with people who live in threat and how we work with people that tend to be overwhelmed and how we help them activate their social safety system. And it can't come through the head. It has to come through the body. Because remember, this is biological. So all of the cognitive behavior therapy that we do is not going to be that particularly helpful You tell yourself to relax. You tell yourself to be calm. There is no danger. The body reacts so much faster to cues in the environment. It's like the nervous system reacts like in 2 milliseconds. The brain reacts in 20. So all of that's pretty fast. But if our body reacts first, it doesn't do any good for the brain it's much later that the brain says, hey, there's no danger, and the body's already frozen and sending messages of danger. So we have to find a way to work with the body. So what we do is we're going to teach people how to activate their social safety system, because the body and the brain, surprise, they're not separate. So we can work with the body to send the message to the brain that we're okay. So if you're out running, and actually this has happened to me because I'm terrified of snakes. So you can be out running and you see, and I go, ah, because I thought it was a snake. And after I've already jumped, I see that it's a stick, and then I can label it a stick. But I've been in panic and jump before I ever get to the word. So words don't help. We need to work with the body and help people be able to activate their social safety system. So I'm going into a group of people. I'm going into a gathering at work. I need to activate my social safety system because I go into threat when I'm around other people. So the answer, it's a huge answer, because a lot of what RODBT is about how to help people come out of the threat substrate and out of being overwhelmed. But one of the ways is to activate the social safety system. So remember the eyebrows? You do remember, right? Okay. The eyebrows have a lot to do with our social safety system. We don't raise our eyebrows when we are feeling threat. So one of the ways, a simple way to activate the social system is through what's called the big 3+1. So what you do, everybody do this with me. You ready? Because it's something you have to feel. Okay, so I want you to sit up in your chair, clench your muscles, lower your eyebrows, clench your jaw, tense everything. Not even frown. Now, I want you to take a deep breath, a really deep breath. I want you to raise your eyebrows. And I want you to lean back and do a closed mouth smile. Can you feel it? No? Yeah? What you're doing, it takes practice for some people, but what you're doing is you're activating social safety. We're activating the muscles that work, leaning back. If we're alert, hyper alert for threat, we usually sit straight. So if we lean back, we're sending a message to the brain, we're safe. Closed mouth smile. It says safe. And raising your eyebrows says safe. So that's something you can do anywhere. And you're not going to look weird, quote. So that's one of the ways of activating the social safety system. Now, I'm going to stop for questions in just a second, but I want to say one more thing. Is that okay? Yeah. So as a therapist, we have certain ways we look at our clients. We are compassionate, caring people, and we try to communicate that with the way that we look. So can you show me your therapy look? What's your therapist look when someone comes in? It's okay, don't laugh. Just give me your therapist look. Okay. So check yourself. So a lot of us as therapists are taught to be serious and lean forward. So if you happen to be an OverControl person, What do you think that says to them? Yes. The overcontrol person sees that as you looking concerned, which you may be trying to do. But what they say, when you ask a group of people who are overcontrolled, what they say is, if there was nothing so wrong with me or so awful with me, why would you be looking so concerned? They see it as you're saying there's something wrong. Remember, they're hypersensitive to threat. They grew up in a perfectionistic family. It's important to them to do things right. So when we look concerned, they're saying, what'd I do? You must think there's something really wrong with me if you're looking that concerned. So the therapist in RODBT is taught to have closed mouth, cooperative smile, lean back, and be chilled. We got this. No problem. We can fix it. You want to signal safety just by your own body manner. Now that's hard because you have this person. We tend to mirror people, right? So you've got this person sitting there, very tense, very serious. It's hard to just sort of lean back and say, yeah, because you sort of mimic them. But that sends, when you do that, that increases their threat. You want to see, because they can feed off of you. It's transactional. So if you can be in your safety system, then they feed off of you with safety versus threat. Okay. I talked a little longer than I said I would, but I was so glad I was wrong about the time. You guys, it's been so nice. The feedback from you has made it easy for me just to keep talking. I could probably talk all night. So thank you for being such a great audience, and I want to try to answer any questions that I can.